Hello, I'm Gilles Salles, now working at the Memorial Sloan Kettering Cancer Center in New York, United States. I would like to discuss with you one of the topics that we addressed during the educational session of the ESH virtual meeting, which was the sequencing of therapy in relapsed refractory follicular lymphoma. I think many items have to be taken into consideration. The first one, and probably the most important, is to realize a new biopsy for any patients that relapse in order to rule out histological transformation that will lead to a different treatment options. For the patient with conserved follicular lymphoma, there are many options that are available. A few data have suggested that those patients relapsing before 2 years, during the first 2 years after initiation therapy, have a dismal outcome. However, this population of patients is again enriched for patients who have histological transformation. And we have seen recently that new agents approved in the setting of relapsed refractory follicular lymphoma are almost equally effective in those patients with POD24 versus no POD24. So I think if the patient has not received any immunochemotherapy before, I think it's probably time to consider immunochemotherapy. If the patient had already received immunochemotherapy, then there are many options. Repeating immunochemotherapy could be desirable in some patients with a large tumor burden. Discussing for this patient autologous stem cell transplantation consolidation or maintenance consolidation is also worthwhile to bring on the table. But there have been new agents that have been approved in this setting. One of them is a combination of lenalidomide and rituximab, or some variations with different anti-CD20 antibodies. And I think that's a very reasonable option for many patients. Other agents approved recently was tazemetostat, the first EZH2 inhibitor, a targeted therapy targeting the epigenetics. The drug is approved for patients with mutation of EZH2, but also later in lines for patients without mutations. And obviously, there are a couple of PI3 kinase inhibitors. Some are approved in Europe or United States, such as idelalisib, other solely in United States, such as duvelisib and copanlisib, and other are in development, such as paslaclisib or umbralisib, and may eventually benefit to this patient. I think when we discuss this treatment for this patient, we have always to take into consideration what's our goal, either a goal to control the disease, either a goal to bring the patient into a new complete remission that may last a few more years. There are different options. The tumor burden has to be taken into account, the patient risk, and we have also to think about the toxicities that can accompany sort of this treatment, whether chemotherapy, transplant, PI3 kinase inhibitors, and so on. So I think for each patient, we need to individualize therapy. There are many agents that are here available. The prognosis of patient is not that bad as long as they don't transform, and each choice should be made wisely for the sake of our patients and to continue to provide them the best care we can. Thank you for your attention.